Ashten Duncan received his Bachelor's of Science in Microbiology from the University of Oklahoma in 2016, Master's of Public Health from OUHSC Hudson College of Public Health in 2019, the Doctor of Medicine from the OUTO School of Community Medicine in 2021. He completed his family medicine residency training at the UNM Santa Fe Family Medicine Residency Program in June of 2024 and is currently a core faculty member at the Médicos del Centro Family Medicine Residency in Española, New Mexico. His professional interests include native and tribal health, outpatient medicine, lifestyle medicine, public health, academic medicine, and applied research in primary care. Dr. Sadoway, before entering medicine, he served as a non-commissioned officer in the United States Army, where he was recognized as a distinguished leader for achieving excellence in the top 3% of his class in a rigorous formal leadership program. He went on to hold leadership positions in multiple businesses and healthcare organizations and continued to be active in leadership training and mentorship throughout medical school. He was both a 2021 to 2023 AHEC Scholar and an inductee in the Alpha Omega Alpha Honor Medical Society. He is a recipient of the Dr. Sam Goldfein Memorial Award and the Commitment to Underserved People Award for commitment to patient care and leadership in medical school while managing a free volunteer family medicine clinic, where he focused specifically on enhancing the therapeutic alliance through patient empowerment. He graduated from the University of Arizona College of Medicine, Tucson, with distinctions in community health, rural health, and global health, and is now excited to be able to call Land of Enchantment home. With that, thank you, both of you. The floor is yours. Take it away.
All right, you all. Well, it's good to see you again. So Dr. Sadoway and I are going to be presenting over leadership in the therapeutic alliance, which is part 2 to our discussion last time. During that particular presentation, we covered the foundations for positive psychology in patient care. And in this one, we're going to take it a step further and show that that overlap between those positive psychology concepts we talked about before and a topic that most people are, at least familiar with to some degree. And so we'll go through some really important concepts in this talk and have plenty of time for discussion as we get toward the end, once we really set everything up. So with that, we'll go ahead and kick off with that obligatory disclosure slide. So doing this purely for educational purposes, no money coming in for any grants or anything like that. So by the end of our talk today, we'll have accomplished 3 things, or at least what we hope everyone will be able to do is summarize key interpersonal leadership concepts and cognitive biases that influence the patient-provider dyad, and articulate the importance and relevance of these topics to direct patient care. Describe how emotional intelligence, self-awareness, and psychological safety impact patient care, and use this knowledge to navigate common patient care challenges. And lastly, to identify the role of the physician provider as a leader in the therapeutic alliance and apply this understanding to cases involving patient care. So I'll kick us off with our first learning objective. So we'll get into talking about some of these concepts, including cognitive biases. All right. So interpersonal leadership, what is this and what are we talking about when we say the word dyad? So interpersonal leadership is this interaction between 2 or more people in which at least one influences the other to achieve a common goal. The most basic unit is the dyad. So we're talking about, this interaction between 2 people. In this case, we'll be talking a lot about that patient-provider dyad because there's a lot of complexity to that relationship, and leadership is really challenging at times because there are times where the provider should lead, and then also other times where the patient should lead, and we should be more in the advisory role. There are many different approaches to leadership, and they really exist more on different spectra. So while we can, kind of give everything a name and say like that's one certain type, all of us will use different leadership styles at different times in order to accomplish the goals that we have, and based on the people we're around. So some of the ones that you may have heard of before, that authoritarian paternalistic style, those were pretty common in the practice of healthcare, back in the 20th century. And I would say, even going into the 21st century, there was still quite a bit that held on for a while, and I think we're starting to see a pretty, solid shift in all of that. Democratic, laissez-faire. And the thing that we really want to highlight today is that there's not really a single best leadership strategy for all situations. So there's not one that's always that's universally appropriate. So different patient situations call for those different approaches, and most people will do this without even thinking about it. The one I really want to highlight today, and one that we'll revisit time and time again, is this idea of servant leadership, which is this dynamic balance of the patient-led and provider-led decision making. So again, kind of this balance where at times you're the one following and the other, at other times you're the one leading. And so the kind of my little soapbox on that is just, if we follow Occam's razor, simplest explanation being the best one, or at least the one most likely to be right, is that, this is most often going to get you the most mileage, and that you'll often accomplish your goals the most effectively by having this more adaptive leadership style. So with that being said, let's talk about adaptive leadership. What does that look like? What are the components of it? And how can we really develop this? So all of these things that we're going to be talking about are skills. I think there are some who would argue that there's some inherent talents behind leadership, but I think those of us who have been involved in leadership roles in the past really recognize that it takes a lot of time to develop the skills and to really sharpen the saw over time. That it's not just something that you just wake up one day just being able to master overnight. And so let's break this down between core leadership and adaptive leadership qualities. So a lot of times when people think of leadership, they really are kind of focusing more on that left-hand side of the screen, these core leadership qualities, the ability to strategize, the ability to act, and the ability to achieve results. And some of the things that you see within these three are things like having a vision, mission, this planning, being able to make decisions and to communicate with a team and to take risks, right? That's I think one thing that a lot of people, when they sit down to really describe what a leader does, risk taking often shows up in some way or another. But let's go over to that right-hand side of the screen. Let's talk about the adaptive leadership qualities that are really important for really nurturing strong teams and achieving that optimal balance and power between those you are leading and those who may end up needing to lead at some point. So there's emotional intelligence, organizational justice, character, and development. And one thing that you'll notice as a theme in all of this is this investment in other people and this understanding of people on a deeper level. And emotional intelligence, we're going to spend a lot more time in a bit talking about that one, but that self-awareness, social awareness, relationship management, I just want you guys just to keep that in your back pocket as we go through this, because as we talk about that, it'll become increasingly important how much of a role this can play in working in teams and leading teams. On the organizational justice side of it, it's much like what we talk about in the practice of healthcare and our bioethical principles, that justice makes a return. And in this case, we're talking about this ability to make decisions fairly and to share information, among other things. Character and development, again, it's just this investment in yourself and this investment in the group to become better than they were previously. And so we're going to expand on all of these and draw some parallels to what we talked about during that last presentation. So interpersonal leadership in healthcare. So I think this one, based on the definition we established a couple slides back, I think probably makes a lot of sense in terms of how this all applies. So the most frequent occurrence that we see this at is at that patient-provider interface. But to note that we also do this a lot when it comes to professional work and intraprofessional work, in the case where we may be working alongside colleagues that share the same professional identity as us. And a lot of the common strategies that we end up using when we're working with our patients are things like motivational interviewing, shared decision making, and collaborative goal setting. And these are more than just buzzwords that kind of show up in the literature and seem to be good ideas. These are just more or less effective ways to work with people and to get buy-in from people, which is something that will make a return later in the presentation. So the central principle to all of this is that the patient should be an active participant in setting their own health-related goals with the physician provider as supporter. So again, some people need a little bit more direct leadership in helping them to set their goals. I think we've all seen those people who will actually call on you specifically to help to tell them what needs to be done and what needs to be avoided. But there are other times where people are pretty keenly aware. They've seen other providers before. They've been through their own health challenges for many years and really just need a little bit more support in what they're doing. So I want to take a moment just to get a little bit of feedback from the audience about this question here. So what factors can you think of that undermine the effectiveness of strong leadership approaches in the patient-provider dyad? So at least over here in Santa Fe, by a show of hands, how many of you all feel like you never have enough time to get through patient visits? Look at that. Hands shooting up left and right here. Frequently enough. Well, that's fair. But let's think about that for a moment, because it's hard to really invest yourself, a lot if you don't feel like you have enough time to really sit down and exercise these skills. A lot of us know what we need to be doing, but it's really challenging when we don't have those resources to be able to do it. Well, what else can get in the way of being able to exercise strong leadership approaches?
Possibly a bad prior experience.
Bad prior experience, absolutely. Poor communication, I see came up, language barriers, trust. These are really important things that definitely affect what goes on when we're trying to be a leader in these situations and to share power, right? Because that's another thing that we have to recognize is that there is a power imbalance that's just inherent in all of these interactions. And so establishing a good balance between the two parties involved is really important. So I appreciate you all sharing. So with that, let's see here. Let's get into talking a little bit about some of the things that you all were hinting at around communication and some of these things that can often undermine our ability to take care of people that we may or may not be aware of, cognitive biases. So the one thing I want to start off with is that a lot of times I think when we talk about different types of biases, there's this inherent negative lens that's placed over them, but we have to acknowledge something about cognitive biases. They're inevitable and they're evolutionarily programmed. They're there to really help us survive. And so our brains do this normally because they're trying to make it possible for us to adapt to situations faster, to filter through information more efficiently, and ultimately to come upon a decision and with expending the least amount of energy possible. So a lot of these are there for a reason, but the problem, becomes when some of these are used to the detriment of other people or are used to systematically disadvantage certain people over others. So yes, and there was the comment made about the brain survives but the heart understands. I completely agree, and that's a really good framework for thinking about this because some of the cognitive biases we have, we can clearly identify. There are explicit things that we do that we're very aware of. We consciously make the choice to use some of these pathways in the brain, but a lot of them, and so many of you probably have already heard the term implicit bias before. These are those unconscious or the subconscious types of biases that can really cause a lot of issues for us as providers, but also for the patients that we interact with, because we're not necessarily actively regulating them. So again, I think what we have to do is kind of take a step back and look at this from less of from a lens of morality, even though morality absolutely does come into play with this when we talk about things like prejudicial thinking, stereotyping, discrimination, and the isms that really come along with those. But some cognitive biases are there for adaptive purposes, and some have maladaptive features. And one thing that Daniel Kahneman had described in some of his work throughout the years was this idea of availability heuristics, which is what you see as all there is, that we kind of frame the world based on the things that we can clearly identify around us. So let's take a little bit of a deeper dive into that and what that looks like, because there are probably going to be some familiar terms that you see over on the left-hand side that kind of help to ground this, because this is all under that umbrella of cognitive biases. Um, the ones that are featured here are just some more prominent ones that I think are at least worth understanding, especially as we go about our day-to-day work and taking care of people. But there are many others that have been described. So again, we increase efficiency, at the expense of careful appraisal of situational context and nuances. So think about how anchoring bias plays in to our care when we're making diagnoses or going about taking care of people that can fall into both explicit and implicit types of bias. And so that's one to note. But everyone has these and brings these biases into situations. But it's important just to recognize when you feel like you're falling into that camp, or to seek some clarity on that if you think things could be at play. The one I think that can be very interesting, and this is true really for both patients and providers, is the Dunning-Kruger effect, and that's one that we can go into later on if you all would like. That there's a certain level of confidence in your ability to understand a situation that comes when you have some information, but not enough information. So here's my question to you all now. How do you think cognitive biases affect the provision and receipt of healthcare services? So basically, so there's a request for some clarity on this question. So basically, how do you think that cognitive biases tie into patients receiving healthcare or healthcare providers providing services to their patients? So what are some situations where you might think that cognitive biases could be affecting care? Okay. So patients misunderstanding health information. Can you expand on that a little bit? In what way might they misunderstand? Dr. Google, right? Yes, absolutely. So yeah, people, right, kind of seeing something. Some people go into it with that confirmation bias, right? They're expecting to see something that they don't want to see, and so they're more likely to see it, even if it is a rare side effect or some other situation where it may not necessarily be a big concern for us. There were in the comments too all the time. That's fair enough because they really are always at play, attributing patients' illness. To a patient's appearance. So things like weight, absolutely. And again, these are things that can happen so fast. And again, if we really just take a step back and realize that these are things that could be happening without our conscious awareness, I think it's something that can really help us there. So anything else on that? Any other times where you've even maybe felt it within yourself that a cognitive bias was affecting your ability to provide care?
If I had, because I'm already biased and I wouldn't know.
So that's a fair point. So that frame in which you operate, so there's this idea of cognitive framing where if we go back to what that quote said from Daniel Kahneman, that all you see is all there is around availability heuristics, you're absolutely right. We may not even just be aware, but knowing that they can always be lurking beneath the surface.
Walk in thinking I know, and then I have to like really force myself to step back and consider a broad differential, because I will sometimes do that and then think I know what it is, even if I don't really.
Absolutely. So a very good point made about anchoring bias and what that can do, especially when you get into the rhythm of patient care, it can be really hard to disentangle yourself from that because it's the way you think and it's the way your brain works. So we'll talk a little bit more about, what we can do, how to identify these things in a little bit and have a more open discussion about that. But let's just take a moment just to talk about cognitive biases and this intersection with leadership. So individual level biases can disrupt the easy flow of information between patients and providers. So for example, the perceived value of health-related behavior changes on the end of patients. So while a lot of patients may have a certain level of trust for you or potentially distrust, there can be a difference in what they perceive as being the value of something that you're recommending versus what you see as being the value. Because many of us have kind of moved away from being kind of the everything. We're always going to just prescribe for patients, when in reality there are many things that do have to go into their own hands, and that's where we can be more of a supporter. But this comes back to buy-in. But remember that discussion we had during the previous talk about goal orientation and that relative priority too, that it can be really helpful to take a moment to assess what the goals are of the patient to figure out where this particular health-related goal might tie into all of that. So a central priority of leadership in the patient-provider dyad is ensuring that health goals align and re-goaling. If you guys remember that discussion from last time, making sure that all of this is possible. So the hope theory framework and the positive motivational states that we talked about are involved in this idea of regoaling. So again, if this initial goal doesn't work, maybe we don't aim for this. Maybe we don't talk about physical activity first, especially if that's something that is not, it's not something that a patient is necessarily comfortable approaching at first. Maybe we talk about eating patterns, for example, things of that sort that can still get us to a similar goal. Absolutely, I agree. So a comment made about flexibility is required. I completely agree with that. If patients are not adhering to a plan, consider barriers to goal attainment and competing priorities in all of this. So every goal pursuit takes energy, and humans tend toward energy conservation. So these are just just some important principles to keep in mind behind all of that. Now, with that, we're going to shift gears here, and I'm going to let Dr. Sadoway take over for our next learning objective.
Sure. So over the next few slides, we're going to talk about how emotional intelligence, which is something you've probably heard quite a bit of already because it's been kind of in vogue for the last decade or so, as well as self-awareness and psychological safety impact patient care. And we're going to try to apply this a little later on as we try to navigate some common patient care challenges. And as we're going through all of this, I want you to think back to the first part of this presentation as we talk about cognitive biases, because in many ways, some of the models that we're going to apply here are really models of cognitive biases as well. So the first thing, as I was just talking about, is we're going to talk about this emotional intelligence. And just to define it quickly, this idea of emotional intelligence is being able to identify and utilize, and those are both key, emotional information to manage oneself and your relationships effectively. And those four ideas, identifying and utilizing, and then applying it to yourself and to other relationships, is really what we're showing on the left side of the screen here with this 4x4 grid. And so all of these are in many ways equally important in developing leadership and the patient-provider dyad. And so the first thing really to focus on is this idea of self-awareness, that if you, so there are a couple of things there. There's this idea of self-confidence and the emotional states that you might be in and the behavioral impact that might apply to the interaction that you're having. And if you don't enter into any sort of interaction without actively thinking about how am I bringing both my cognitive biases that we just talked about and my current emotional state into this situation, then you're going to it's going to be a lot more difficult to have any sort of positive interaction. And the idea of self-awareness then plays into this idea of social awareness, where if you come into, say you come into a room to see a patient and you've been having a bad day, or you've been having a great day, you can either use some of that positive energy to work the room and help recognize what's going on in the room and engage the patient in your talk, or you might have to mask some of the bad day that you're having. But you also have to have this social awareness where you recognize what the person you're talking to is going through. And we'll go into that a little bit more in the next couple of slides. But every interaction you have is going to require a very different approach based on very rapidly ascertaining the situation. And so this is again where some of these cognitive biases come in. You can use them in some cases to your advantage to quickly assess the situation. And then the next part we'll talk about is management. So self-management. Again, you've recognized what sort of emotional state you're in, and now how are you going to control that? How are you going to use it in pursuit of the goals that you're trying to obtain in the room? And then how does that apply to relationship management, where you are actually so you're handling conflict, you're expressing ideas, and the real core to this, you'll see at the bottom there, is empathy. trying to understand what's going on the other side of this two-person interaction. And there are a lot of resources that that people can use to assess their own emotional quotient, this EQ idea. You may have used some of them before. We can give you resources if you're interested in doing more of a self-assessment. But I think the important thing is that there's been a lot of research on this over the last 10, 20 years, showing that the higher your emotional intelligence is, the more effective you're going to be in leadership in any situation. And so it's really important as we talk, going back to that patient-provider dyad, that you are actively working on developing emotional intelligence in order to build this therapeutic alliance with your patients. And one of these foundational models of self-awareness is the Johari window model. And I think a lot of this is kind of seems almost obvious, but the reason why we have a model like this is because even though it seems obvious, if you don't take the time to actually think about it, then you're going to miss things. And so the model shows, again, 4x4 grid, that there is some knowledge that you know and that other people know, and that's considered shared knowledge. And I think this is actually a key area where we often run into problems in interactions, is that we think that there are things that are shared knowledge that are not. You see this a lot when I'm sure many of you have gone into a room and started talking in all sorts of medical jargon, or even things that don't seem exactly like jargon, but that you assume that the other person knows what you're saying, and they're nodding along, saying yes, 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 but actually that's not completely shared knowledge, because you are both entering this interaction with different foundational knowledge. And so that's an easy way to run into some cognitive bias. And then of course there are areas in this gray box that are unknown to everyone. And it's important to recognize that there is going to be uncertainty in any interaction, and as you enter into any leadership situation, that you don't always know what's going to come next. And there's a lot of knowledge that we can't easily know. And if we don't recognize that and say that at the outset, then we're going to run into problems. And then I think the real key for focusing on any sort of leadership interactions is these other two boxes, the green and the red. And so there are things, these hidden areas where they're known to self but unknown to others, things that maybe we're masking intentionally or unintentionally. And then blind spots, really key, that are unknown to you but are known to others. And so you might walk into a room and have an interaction saying, why don't, let's suggest this, take your statin, go do whatever you're trying to do in a medical role. But you're missing all of the social determinants of health and all of the things that the patient thinks maybe things are shared knowledge, maybe things are very obvious, but without a much deeper dive into speaking to this person, you're not going to realize that there's a blind spot there. And so I think it's really important. There's been a lot of research that demonstrates the benefits of using this model in feedback and resident education. And it's especially applicable to patient interactions. Everyone has blind spots, things that others know that are unknown to you, and trying to elucidate some of this will really help with building shared goals. And again, going back to that patient-provider dyad. So this, the other core thing about this framework is that it really supports the role of allowing the patient to lead in instances where they're the expert. So where you're in one of these blind spots, because patients are going to know themselves better than anyone else. And if they can communicate some of that knowledge to you, then you both can work together for a shared goal. And in order to do that, you really need to focus on building psychological safety, which is what we're going to talk about next. So I think, again, this is something that seems somewhat obvious, that you need to have psychological safety to have a good interaction. But if you really think about it, it's not always so obvious how to get there. Again, with definition, psychological safety is this idea of being able to show and employ oneself without fear of negative consequences to self-image, status, or career. And I think a lot of the times the negative consequences to self-image aren't always obvious. People, because they have different priorities, might find that some things are harder to talk about or harder to do because they may not be completely stigmatized by society at whole, but they feel unsafe to the person. And trying to get into that mindset of the other person and what does psychological safety look like to you can really help improve the patient provider interaction. And so you see in the model here, we have a lot of inputs: role clarity, peer support, interdependence, learning orientation, positive leader relations, open and welcoming communication, and really key here, absence of stigma, which is something that, again, you can't always know. Sometimes it's a blind spot what actually the stigma is, and you can't always stop societal stigma around something. But going into an interaction where you are very open to letting people speak their own truths and not outwardly judging them helps create this absence of stigma to the best of your ability and helps develop some of that psychological safety in the group. And so what you get out of that is that you get better information sharing. And it's not just from the patients, but you also get work satisfaction. You feel like you're doing something better that helps prevent burnout, some of the other things we're talking about. It helps with in a learning environment or residency situation. It helps with better learning behaviors, better engagement, better performance, and you end up being less in that survival mindset, and are able to focus more on some of the higher order goals. And this is directly related to patient safety outcomes and team member well-being. And it's really one of the key roles of a leader. We talked about some of the core leadership practices earlier, and one of them is setting overarching visions. And so leaders have the power to create an environment of psychological safety by creating an organizational vision that encourages sharing power with those being led. And so, and really, in that case, by sharing power, you're having leadership on both sides. And that patient provider dyad is really leading the situation. It's not an authoritarian top-down leadership. And so very, very important to try to engage the patient, as we all do, as an active participant in their healthcare plans in order to get those patients to better put those healthcare plans into practice in their own lives. And so we already kind of talked a lot about why this matters, but this nice bullseye target model shows us that basically you want to work your way from the outside in, and if you don't have an environment of psychological safety, then you're going to get a lot of silence, and you're not going to get the information that you need. And more importantly, the patient that you're talking to isn't going to feel comfortable sharing things or showing you some of those blind spots that you might have missed earlier, and where they might not be able to feel like they have a say in the plans or be able to implement those plans because of other things that are going on. And you can get to a point as you improve your organizational psychological safety where people feel fairly safe and they're willing to talk to you, but that's still not the center of this bullseye for a reason, because going even a step further allows you to build shared meaning. And that's, if we go back to that Johari window model, that's that top left corner where you're getting more shared knowledge as well. And so both people are talking essentially on the same wavelength, and you're able to put into practice some of the things that you're talking about a lot better. And so we've been talking about this for a little while now, but I want to pose a question to the audience. And I want you to think back on some of these models we just talked about, and think back on some of the cognitive biases we were talking about earlier. Without psychological safety, how can you be sure you have all the information you need from others? I see there's something in the chat. You really don't, you just assume mostly. And that's a good point. And that's getting back to that concept that you don't always have the same shared knowledge. And without psychological safety, you probably aren't going to get a lot of the knowledge that you need to build that shared knowledge base. Anybody else have any thoughts on this?
Site verification, multiple source.
Yeah. And that's a good point too. I mean, getting collateral is really important. Having some objective data to help, certainly. Asking. I mean, asking, and that's really the key, right? So asking is, it's not really without psychological safety. Asking is building that environment of psychological safety. And if you have built it successfully, then when you ask, people may actually answer. And then that's when you start working together to get the information. Not threatening the patient.
All right, you all. So we're going to go into a little bit more discussion here in a moment, but I just wanted to cover a few more things for us to think about as we look at physicians or other providers as leaders in the therapeutic alliance. And we're going to talk about this in the context of cases and some open discussion questions. But first, let's just set the stage for therapeutic alliances. What do they look like? What are what's a part of the therapeutic alliance? What is not? And this diagram here will kind of walk us through each component there. So the definition for the therapeutic alliance is a goal-focused partnership between patient and providers centered on mutually agreed upon tasks. So again, active participation from both parties, in that partnership, right? We're sharing that power. We're goal focused too, in a way where we both agree on what's going on because we're both coming together to really form this set of goals that are important for both of us in this alliance. And there's a lot of overlap with motivational interviewing techniques that I'm going to show you in just a moment after we have a chance to talk about this framework. But let's go one step at a time with that first one. So investing in the beginning. So this is that when you walk in, you establish rapport. Hopefully you're not fighting your patients or anything like that, but you get to the point where you can have that easy communication. You can have that psychological safety that we just heard about, and you're eliciting concerns from the very beginning to understand what's important to the other person. And that's where that idea of agenda setting comes in, because that way you know what's going on, you know what you need to accomplish and how you're going to get there. Next is eliciting that perspective. So that idea of asking is coming back around there. What ideas do you have for what's going on? What do you think is driving all of this? What do you think needs to change? That can give you some early clues as to what those specific goals and requests are. So in an effort of eliciting this perspective, you're getting a lot of information at one time, and then also establishing what the impact is of whatever it is that's important to the patient on their life and what that looks like. Demonstrating empathy. So, availing yourself to emotions, actively expressing empathy and conveying that empathy through your nonverbal cues, because all of this is really important, because going back to that whole point of entering into that pool of shared meaning with the patient, it takes time to build trust, especially, today when people are exposed to so much information that can maybe make them a little distrustful coming into this interaction. But you can really reverse a lot of preconceived notions people have by showing them a genuine, authentic person who's really there and willing to help them. And investing in the end. And this is an important part. This is why, we often will say, don't end a meeting by planning to have another meeting. You should go into this with actual clear, information. You should go into this being able to inform, educate, and counsel, and ultimately come up with the game plan for next time. What will each of you be doing to help promote those goals that you set in the beginning by that next encounter. And so the big takeaway from all of this is that providers and patients are the leaders in this alliance and share power to promote active participation in the processing or in the process of producing change. And so when we look at the motivational interviewing side of it, this probably looks a little bit more familiar to everyone. We have the classic ORS acronym up on the screen right now. But a lot of this comes back to the same things that work in motivational interviewing: asking open-ended questions, using affirmations, listening reflectively. So a lot of this really does come back around fully to the things that we know are true and the things that we probably actively practice all the time. So in many ways, the therapeutic alliance can emerge from a lot of the same things we may already be doing, but at least in this way, you have another framework to look at your interactions with patients through in order to achieve the best outcomes possible. Now, something that was alluded to earlier is self-assessment for emotional intelligence. You have a QR code on the screen. You're an oh no from the crowd over here. And so we've got, I promise this won't take too long because as Dr. Sadoway really said very, very well earlier, there's a lot more to the self-assessment than we have time for right now. But we will give everyone just a few minutes to scan that code. It's going to take you to a website where you should be able to go to the bottom there to access the questionnaire that will go through some multiple choice questions with you. And at the end of it, we're going to talk about what you all found, but we'll give everyone a few minutes to just take a look at that. And if you wouldn't mind dropping a message in the chat or letting us know once you're done, that way we can get on with discussing what you all found from this. All right, so with that, go ahead. And just before we talk about everything with the emotional intelligence, that mini self-assessment you just did. Why don't we talk about a case here? I'm going to let Dr. Sadoway take the lead here, and then we'll go into some more discussion in a moment about what you just did.
Sure. So we want to take some of the things we've been talking about and apply them, as I'm sure many of us do every day. And so we have a specific case here. Peter is a 57-year-old man. He's got multiple chronic diseases, requires him to take 7 medications every day, and he's coming into clinic to establish care with you. And you start talking to him, and topic comes out about his blood sugar and his blood pressure, and he becomes really reticent. Seems uncomfortable discussing his chronic disease management. And he mentions to you that he feels hopeless about ever getting his life under control, and he averts his gaze. I think some of you have probably been in a situation like this before. I want to open this up to the audience. How have you approached cases like this? How would you approach Peter in order to establish a therapeutic alliance with him? Okay, I'm hearing empathy in the room.
Yeah.
Yeah. Okay. So I ask him to clarify what he means about some of these things. Think back to some of the models that we've been talking about today. Is there maybe a cognitive bias or a knowledge gap that might exist here? Okay. So he's trying to find out more about what he has dealt with and his feelings. Great, exactly.
Don't know why we still don't really understand why he doesn't have his blood sugar or blood pressure under control.
Sure. Yeah, we don't. So, yeah, so I'm hearing in the room we're lacking information. We don't know why he doesn't have his blood sugar, blood pressure under control. And I think the other thing that we don't know is what is his goal. This is the first time we've ever met him. We haven't necessarily built that psychological safety yet, and we don't know much about him other than the numbers we see on a page. And so I want to ask a few more questions. What cognitive biases do you think might be contributing to Peter's perspective on his chronic health conditions? And kind of expanding on that too, what cognitive biases might we have going into this? Sure. So could be that he's tried before there are health literacy issues. I see in the chat it's difficult managing a chronic disease. Absolutely it is. And it's difficult managing a chronic disease both from our perspective and also from the patient's perspective, who in this case, Peter seems very frustrated with, he's on 7 medications. He's probably been trying for quite a while to get things done. And then it makes you wonder, is he taking these medications? If so, why not? What is his goal? And I see in the chat also listening without putting blame on the patient's behavior. Absolutely. 100% agree with that. Trying to find out more about what he's dealt with and his feelings, his understanding of the disease. That's also a really key one. And that goes back to that idea of shared, sometimes we think we have shared knowledge and we don't actually share that knowledge. What do you think Peter's behavior suggests about his emotional state? And playing on that, how do you think you could manage his emotions to achieve a better outcome?
Maybe he's overwhelmed with all the medications and maybe not understanding very well what is the goal for treatment. Make him a little just difficult to take all the medications, or maybe he's scared of taking all the medications because thinking that they're gonna be harmful as well.
Yeah, maybe he's overwhelmed. Maybe he thinks things are harmful. And I think really what you're getting at here is we don't know. And how can we how can we find out? Well, we can find out by asking, first of all. But then also by building a culture where maybe he feels comfortable telling us these things. So, do you think Peter feels psychologically safe? And if not, how might you apply some of the leadership skills we've been talking about to build psychological safety in this encounter?
I think that's empathy and help him that it is difficult to control a chronic disease. In the beginning, because of the him not being able to control his chronic blood sugar, hypertension itself. And another thing is his he feels a little bit judgmental maybe to this experience, so that's why he may be defensive.
Yeah. And I think that goes back a little to what I was talking about earlier about we don't always know what the stigma is when we're trying to avoid stigma, is that maybe he feels judged over not having these chronic conditions under control. And I think there's a really good comment in the chat. It says, remind patients of things that actually are in his control to gain perspective. A lot of times people want to control something and they go into the doctor's office and they feel powerless. Like, I'm coming in and someone is telling me what to do, and I'm going to go home and it's just not going to get any better. I'm not going to be able to do this. But there are many things that are in people's controls. And, we talked about, like, if you were here last month in the talk about how small things like getting that A1C down 0.1%, that is meaningful progress, and highlighting some of that and saying that you have done this and you have made a positive change can be really helpful. And the other comment I see in here from Mario is offer to answer Peter's questions and sit across from him, putting yourself at an equal level. At the University of New Mexico, they have this big Commit to Sit initiative. And the idea is that you should sit down and be eye to eye with patients when you're talking to them, because it does build that it increases the idea that they feel like they're part of this patient provider dyad, and that they're both making decisions, that the patient is empowered to make decisions and to speak in this environment of psychological safety. Any other comments on this?
Ask him openly what we can do to help him, what he thinks is his biggest maybe barrier.
Yeah, that's a really good one. What do you think is the biggest problem coming in? Because we have a lot of these biases, and we say, well, your blood pressure is the problem, your diabetes is the problem, but what does Peter actually think is going on? It gets back to someone was talking about earlier, what is his understanding of the disease, but also what are the priorities in his life and how can we help support that? Yes, first says it.
But soon, so we can study the relationship, because if you're going to study the relationship, it's very difficult to really help. So I ask what he thinks about coming back.
Yeah, absolutely. And that goes back to building some of that psychological safety. Seeing somebody multiple times in a short time span early on can be really helpful to increase their buy-in into their treatment plan. Instead of seeing somebody once and saying, come back in a year, or come back in 3 months and we'll check your A1C again. It might, in Peter's case, that might be too long. And so understanding, why some of these conditions aren't well controlled and what Peter's thoughts are on them can really help us understand where to go from there. So how do you think adaptive leadership principles lead to the development of a therapeutic alliance? And I think we talked a little bit about this, but does anyone have any thoughts on that? I think Montserrat, you were explaining some of that just now. We can go on. Before we get into the conclusions, which is the next bit, does anyone else have anything they want to add on this case with Peter? I see something in the chat. Involve the patient in the treatment. Absolutely. So that's going back to that patient empowerment, that leadership. There are many different styles of leadership. And there are times when some of that top-down authoritarian leadership may be useful. But for most cases, having shared leadership is really going to get you the best outcomes. And inquire about what are his challenges to achieve control. Exactly. So, and even more than that, what are his, does he want control? What are his goals in this? And so we're getting close on time. I want to respect your time. We'll go over to conclusions now. That strong and adaptable leadership is really central to this patient-provider dyad. And cognitive biases are ubiquitous. They can lead to fallacious conclusions. Providers need to be cognizant of how these biases influence care and what biases that the patients might have that they're bringing to this interaction as well. And a lot of that comes back to emotional intelligence, understanding where you are, what your emotional intelligence is, where you can grow. It's really central to strong leadership, especially when we're talking about styles like servant leadership, which is often the Occam, as we said, Occam's razor are often the best way to do things. And building that framework of psychological safety, really important to promote open communication and develop that therapeutic alliance that ultimately is the product of strong interpersonal leadership involving the sharing of power. And I think the last thing on the slide that I really want to highlight is that leadership skills are not innate. You might see someone that is very charismatic, can walk in and command a room, but that's not the same thing as leadership. Leadership skills are learned behavior, and we can study them, we can put them into practice, and all of us can get better at being leaders in every situation. So I want to say thank you very much for having us. Yeah.
Yes, thank you all, and thank you for your attention today. Let's see here. Oh yeah, thank you for your comment there. Yeah, so next time around, we'll be having another co-presentation during our first Wednesday in April. Different topic. We'll have more to share with you all soon about that. So just be on the lookout for announcements there. Definitely want to highlight Mario's point too about giving us feedback on all of this as we kind of develop the series further, and just get your input too about how today's presentation went, different topics that you might want to hear about in the future. And then for anybody it applies to at 1:45, yeah, we'll be having that faculty development talk. So thank you all again.
Thank you.
Thank you, everyone. If you do want the recording, it will be posted on our website, or you can email me at acastillo@nmpctc.org. Thank you so much.